Welcome to our ASSFN webinar this evening. My name is Sharona Benheim, and I'm a functional neurosurgeon at UC San Diego. Tonight, this will be the first of a five-part series that will be running over the next several months that'll feature salient topics around epilepsy surgery and surgical decision-making. This evening's webinar is really designed to cover some foundational topics in the realm of the neurology and the neurophysiology and really some of the real basic ideas and concepts around the surgical decision-making behind epilepsy surgery. And I am delighted to introduce our two moderators this evening, Danica Paolo, who's a functional neurosurgeon at Henry Ford Health, and Neha Sarmay, who's a functional neurosurgeon at the University of Arizona in Tucson. Thanks for being with us tonight.
All right, thanks for the introduction. It's great to see so many people joining, and I think there's many more to come as well. Good evening, everyone. I think this will be a great session we've got planned today. My name is Neha, and I'll be co-hosting this with Dr. Paolo. So we're thrilled to have today with us three accomplished experts to speak on their perspectives on the current state of epilepsy and surgical management, kind of a foundation, a look into to start out this whole series. So what's interesting about our speakers today is we have representatives from different disciplines, and I think this is very important because it really sets the stage for how we think about epilepsy surgical care, because it's really a multidisciplinary approach that's required to care for these complex epilepsy patients. So we'll have speakers from epilepsy, neuropsychology, and neurosurgery as well. So Dr. Paolo and I will give a brief introduction on each speaker. Each speaker will give us about a 15 to 20 minute talk, and then at the end of the session, we'll have a Q&A, about 15 to 20 minutes to engage with the audience and answer any questions and have a good discussion, hopefully. So our first speaker I'll be introducing is Dr. Jerry Shi, who is a professor in the Department of Neurosciences and the director of the Level 4 Epilepsy Center at UC San Diego. Dr. Shi obtained his medical degree from UCLA, then completed his training in neurology, followed by clinical neurophysiology and critical care neurology, also at the same institution. He later became director of the Mayo Clinic Epilepsy Center in Jacksonville, Florida, after which he moved to UC San Diego. Apart from leading a robust epilepsy clinical practice, Dr. Shi is committed to the education of medical students, residents, and fellows. He is extensively published with over 60 peer-reviewed articles. He's a reviewer for several respected medical journals. So we're looking very forward to his talk on the epileptologist's perspective on refractory epilepsy and teaching us some fundamentals of EEG and semiology. So I'll hand it over to Dr. Shi.
Thank you very much for that very nice introduction, Dr. Sarmi. I appreciate that. Let me go ahead and share my screen. Can people see my screen?
Not yet.
Not yet. Let's try that again. How about now?
Yep, that works.
Okay, excellent. Thank you. Thank you again for that kind introduction. Yes, I'm here at UC San Diego. I have the pleasure of working with Dr. Benheim, who's one of the organizers for this webinar. And I am here to try to condense 2 years of epilepsy fellowship into 15 minutes. No, just kidding. We'll try to hit some of the highlights and the major points. And so I am going to be talking today on basically the epilepsy or epileptologist perspective on seizure semiology and EEG findings in the surgically remediable epilepsy. So I really won't be talking a lot on some of the other epilepsy syndromes that you as neurosurgeons are not likely to see. Here we go. So in terms of the presentation, I am actually going to very quickly talk about seizure classification. Dr. Benheim asked me to sort of very briefly talk about that, but then focus the rest of the talk on seizure semiologies for some of the common drug-resistant focal epilepsies, as well as talk about what we tend to see classically on the EEG from scalp, as well as intracranial EEG when we evaluate these patients for possible epilepsy surgery. So in the year 2025, last year, the International League Against Epilepsy, ILAE, published a position paper on the operational classification of different seizure types. And so the main thing is that there are three main seizure types. But what I'm going to do is, by the way, can you see my cursor moving? Yes?
Yep, we can see it. Yeah.
Excellent. I'm going to actually focus more on the focal onset seizures because I think those are the type of seizures that as a combined group that we will tend to see. So the current description or classification of focal seizures is you got three main types. You have focal seizures with preserved consciousness, you have focal seizures with impaired consciousness, as well as focal seizures which progress or evolve to bilateral tonic-clonic seizures. So these would be the sort of the three main seizure classification types that you'll hear in epilepsy surgery conference. Now, the interesting thing is that was published last year. But if you talk to colleagues who've trained earlier, you will hear probably some different terms. So prior to 2025, we've been using the term from the 2017 position paper in which, again, the differences aren't that much. You still talk about focal onset seizure with preserved awareness, or focal onset seizures with impaired awareness, or focal to bilateral tonic-clonic seizures. So that was 2017. But if you read papers published from over 10 years ago, or if you have colleagues who trained over 10 years ago, they are probably going to be talking about some slightly different terms, and that's partial onset seizures. So the term partial is now substituted by focal. And before, the seizures were called simple partial seizures or complex partial, which denotes an alteration of awareness or alteration of consciousness, or seizures that are partial onset, which evolve to secondarily generalized seizures, basically the ones that evolve to a tonic-clonic or grand mal seizure. So these were some of the older terms. I can tell you, you will still hear these terms bandied about. So it's good to know that those terms for your sort of educational purposes. I'm going to switch quickly now to sort of seizure semiology. This is actually, I think, a nice graph or pictorial from a review paper on seizure semiologies from a few years ago. I'm actually not going to talk about all of this, but I just want to point out that, you know, when you look at seizure semiology, they're actually basically a denotation of our understanding of functional neuroanatomy. So if a seizure is affecting a certain part of the brain, let's say the visual cortex, you're going to get visual symptoms. If they're affecting the auditory cortex, you're going to get auditory symptoms. So, but I think this is a nice pictorial that lets you sort of see what the different, for lack of a better word, signs and symptoms are when patients have seizures originating in that area, or when seizure activity propagates to that area. What I do want to do is spend a little time to talk about some of the more common seizure semiologies. So all of you who are going to handle, epilepsy surgery are going to come in contact with patients with temporal lobe epilepsy. This is the most common type of drug-resistant epilepsy, and in my experience across 3 institutions, it's the most common type of seizure that is going to come for surgical evaluation and intervention. So temporal lobe epilepsy has actually a fairly classic presentation. So what I want to impart to you is that temporal lobe seizures are classically hypomotor. Patients with temporal lobe epilepsy typically present with their seizures in which they will have a sudden behavioral arrest. If they're talking, they'll stop talking. If they're doing something, they'll pause. They may or may not have sort of hand or oral automatisms, and these are accompanied by variable degrees of sort of alteration of awareness, and most of them last anywhere from about 30 seconds to 2 minutes. And post-ictally, they're confused, they're fatigued, usually for anywhere from about 5 to 40 minutes, typically. Patients will oftentimes say, before I lose awareness, I actually have this very stereotype or very consistent warning. And those warnings are oftentimes déjà vu symptoms, gustatory hallucinations characterized by just an unpleasant taste or unpleasant smell, or a sensation of fear and doom. And different patients may have a subset of these auras, but for a particular patient and their particular seizures, it will almost always be that stereotyped aura. And auras, by the way, are also known as focal aware seizures or focal seizures with preserved consciousness. So that's what auras typically are, but classically hypomotor. The other common type of seizures that come for potential surgical intervention are those that come from the frontal lobe. And in differentiation from those with temporal lobe epilepsy, patients with frontal lobe seizures typically present, when their seizures occur, in a very hypermotor or hyperkinetic fashion. You can see very commonly, extension of the limbs. You could see clonic movements of the limbs. Sometimes you can see thrashing or turning, but again, a very active sort of seizure compared to the temporal lobe seizures, which are oftentimes very bland and quiet and without a lot of motor movements. Frontal lobe seizures are also typically fairly brief, typically less than the temporal lobe onset seizures. Usually, in my experience, anywhere from about 10 to about 40 seconds for an individual seizure, although, again, these may cluster. Frontal lobe epilepsy patients tend to have seizures that can occur in clusters. They can have prominent vocalization, and commonly, we see them out of sleep. So if a patient is seen in clinic and they tell me, Dr. Shi, 90% of my seizures come out of sleep, that's a sort of a little tip-off that, okay, maybe I'm dealing with a patient with frontal lobe epilepsy. The other thing to know about frontal lobe seizures is they are semiologically complex. So what I mean is this. If I see patient 1, patient 3, patient 5, patient 10 with temporal lobe seizures, they kind of have that similar bland hypomotoric look. But if I look at 10 patients with frontal lobe seizures, they're hypermotoric, but they kind of look different, each and every one of them. So semiologically, it's a more complex appearing seizure and therefore it can be a little more difficult to interpret. And that's most likely due to the fact that in the frontal lobe, there's widespread connectivity to other regions within that frontal lobe, to the contralateral frontal lobe, and to other portions of the brain. And so when you have that rapid potential propagation, it activates multiple different areas, and that's why we tend to see a more complex semiologic appearance to them. So I think some of you are going to say, you know what, I think he's going to show me parietal onset seizures or occipital onset seizures since he showed me temporal lobe and frontal lobe onset. Sorry to disappoint you. The reason why is because seizures coming from the parietal and occipital lobe consists of a very small subset of patients with focal epilepsy. And certainly from a surgical intervention perspective, I can tell you I can count on one hand the number of patients with parietal lobe onset seizures that have gone for surgical attention. Okay, so those are relatively uncommon. What is also uncommon, but more common than parietal or occipital lobe seizures, are seizures coming from the insular cortex. Okay, and even though these are uncommon, you will see them when they're presented at conference, but also you're going to see them at national meetings. And you're likely going to see one if you go to a session, whether it's at the Neurosurgical Conference or the American Epilepsy Society Conference. If they're talking about unusual cases, insular seizures are oftentimes going to come up. And the reason for that is because they can be hypomotor, they can be hypermotor. And the insula can be sort of thought of as functionally divided into an anterior portion and a posterior portion. And classically, seizures coming from the anterior insula are associated with abdominal symptoms, laryngeal constriction, autonomic signs, so nausea, changes in blood pressure, diaphoresis, whereas seizures coming from the posterior part of the insula typically are associated with paresthesias and painful sensations, burning, electrical sensation, tingling. So slightly different depending on where in the insula it comes from. But even these symptoms that I've told you about are just a subset of symptoms that have been described for patients with insular onset seizures. So patients with insular onset seizures can have a heterogeneous semiology, and again, that's thought to be because of the rapid propagation of electrical signals out of that insula to the contralateral insula and then other portions of the temporal and frontal lobe. Okay. I'm going to move forward and talk about seizure patterns. So what I want to indicate to you is that there are two main patterns when we look at the EEG, the ictal patterns. One is progressive, one is non-progressive. Focal onset seizures always have a progressive pattern. Okay. So when I say progressive, what do I mean? What I mean is when you look at those EEGs that are shown to you, you will see that the EEG changes in terms of the amplitude, the frequency, and the distribution of rhythmic or sharp activity. And very briefly, I'm going to use my pointer to point out that this patient is having a right hemisphere onset seizure. That rhythmic activity you see here is changing. It's increasing in amplitude here. It's decreasing in frequency, and it also involves part of the brain that wasn't involved before. So evolution in terms of amplitude, frequency, and distribution. I just want to point out that when we look at EEG from the scalp or from intracranially, depth electrodes, strip electrodes, grid electrodes, they look a little different. In the scalp, about 2/3 begin with a sort of a rhythmic sort of sinusoidal waves. 1/3 begin with sort of spikes or repetitive sharp waves, and they typically are, most of them, between 4 to 7 hertz. Okay. That's different than intracranial recordings. When we look at intracranial recordings, depending on which study you read, the majority of these recorded seizures actually are low voltage fast activity, over 13 hertz, usually under 10 microvolts. That's the vast majority of the recordings. Some of them consist of rhythmic sharp waves under 13 hertz, but those are sort of the typical patterns. And now I'm going to sort of show you some of those patterns. So here's a patient in our unit who had a recorded temporal lobe onset seizure. Okay. And what I'm going to show you is she starts out, she's going to adjust her pillow, and she's going to hold it back, and boom, pauses, drops the pillow. Okay. That is not voluntary. And right now she sort of is in that hypomotoric state. She's going to sit here, and you may not see it. By the way, she's already seizing. You can see that rhythmic activity on the EEG. The lips are puckering a little bit. You may not be able to see that well. Take my word for it. But she's not moving. And you're like, well, maybe his video's frozen. You can look at the blinking light of her bed right here to let you know that this is ongoing. But look how still and silent she is. This is a typical frontal lobe onset seizure. And I'm going to let this play a little bit because I'm going to show you how this seizure evolved to where she goes into a bilateral tonic-clonic seizure, otherwise known as a secondarily generalized seizure from some of the past classification terminologies. So now you see her head slowly deviating to the right, and then you're going to see her arm start moving. So this has evolved into a generalized tonic-clonic seizure. Okay. For the interest of time, I'm going to pause this here and move on. So looking at her seizure, and here I just want to point out this. So here she drops her pillow. So her brain is already seizing, but you don't see any of that rhythmic activity. But over time, I think I can convince you that you see rhythmic activity, and this is 6 hertz, by the way, so between that 4 to 7 hertz range, 6 hertz rhythmic activity that begins in the left temporal lobe and actually fairly rapidly spreads to the right temporal lobe. So again, evolution in terms of frequency, and then as this goes on, she actually goes into a higher amplitude, slower rhythm, which I won't show you, but again, that evolution in terms of amplitude, frequency, and then distribution. So starting in the left, but then anatomically moves over to other portions of the brain. Now I'm going to show you a frontal lobe onset seizure. I want you to sort of see the slight differences. So by the way, this gentleman is sitting in a chair and he's dozing off. So he's actually asleep. Okay. And you're going to see sort of that electrical activity come in. So he's still asleep. But that seizure starting, and then that first indication you'll see in a couple of seconds is he's going to have a bit of motor activity. Boom. Left arm stiffens, tonically stiffens. Left leg is going to stiffen and have some clonic movements. Head is deviated to the left. He still has some movements here, which you may or may not see on his hand. But again, very prominent motor movements that I hope I can convince you looks a little bit different than the other one. Okay. And he's going to be sort of moving about in the chair, shifting. EEG-wise, a spike followed by repetitive sharp wave activity, and then again, that evolves. This is over the right frontal polar area, evolves to a higher amplitude, and then spreads to involve other portions of the brain that was not involved at the very onset. So that evolution. And then I'm just going to finish up by showing you this patient who actually has intracranial electrodes in. Okay, now I want you to focus sort of on this area here, because this is where electrodes are in his left insular cortex. So he's kind of just relaxing there. Oh, he feels something. He tries to reach for the button, and you can see he's sort of hypermotoric at the beginning. He's moving his arms, he's shifting his legs, okay? And then he kind of calms down. You know, that arm is, yes, still moving, but he's actually looking pretty calm here. But that initial movement was fairly hypermotoric, followed by a more relative hypomotoric sort of clinical presentation. Okay. I just wanted to sort of show you that. And let's go to his EEG. So LI stands for left insular. We had electrodes placed in the anterior nucleus of the thalamus, cingulate gyrus, Heschel's gyrus, amygdala, hippocampal head, hippocampal body. So you're starting to see that rhythmic activity here in the left insular contacts, which then over time propagates to the amygdala, and the left hippocampal head, hippocampal body, hippocampal tail. So that evolution in terms of amplitude, frequency, distribution. And the point I also want to make here is this, is when we're doing intracranial EEG sampling, you only see what you're sampling. I know that sounds self-evident. I know that sounds kind of non-profound, but it's a truism that we need to take into account. If we're not sampling an area of the brain, we don't know what it's showing. So the point I want to make is even though the onset's here, if this area were not sampled and you only saw hippocampal onset, you'd be sort of leaning towards maybe this is coming from the left amygdala, left hippocampal head. Whereas in reality, the onset is in the left insula. Okay. So my last slide. I just want to emphasize again, temporal lobe onset seizures tend to be hypomotoric, while frontal lobe seizures tend to be typically hypermotoric. When we're looking at EEG, whether it's on the scalp or intracranially, the seizures tend to manifest. When you're looking at the EEG, you should be seeing changes in frequency, amplitude, and sort of the anatomical distribution of those rhythmic or sharp wave electrical activity. Thank you very much for your attention.
Thank you, Dr. Shi, for that great review of the subtleties of seizure semiology and how it can help us localize where the seizures are originating from, as well as some of the EEG correlates that we can see. I'm Danica Paulo. I'm the other moderator for this session. I'm a functional neurosurgeon at Henry Ford Health. It's a pleasure to be with you all tonight. So getting into our next speaker, it's my pleasure to introduce Eva Alden. She is a clinical neuropsychologist in the Department of Psychiatry and Psychology at Mayo Clinic in Rochester. She earned her PhD in clinical psychology from Northwestern University School of Medicine, then completed a neuropsychology-focused clinical internship at the University of Florida and completed both residency and a postdoctoral fellowship in medical psychology and clinical neuropsychology at Mayo Clinic. Her clinical and research interests include adult neuropsychological assessments, psychometrics and normative data, intraoperative cognitive mapping and monitoring, and improving quality of life and functional outcomes for patients undergoing neurosurgical treatment for conditions such as epilepsy. Today, she's going to share her expertise and insights with us on the neuropsychological considerations that inform surgical decision-making, particularly when operating in eloquent cortex and the dominant hemisphere. So thank you, Dr. Alden, for joining us.
Thank you for the introduction and the opportunity to present. Hopefully everyone can hear me okay. All right, I will share my screen. Okay, and hopefully everyone can see my slides here. So today I'm going to share my perspective as a neuropsychologist and talk about what our role is in the pre-surgical workup, and then hopefully give you some case examples about both intra and extraoperative cognitive mapping. So I'd like to start with a brief history lesson. Hopefully everybody recognizes these two very handsome gentlemen. On the left, we have Paul Broca, and on the right, we have Carl Wernicke. So they're classically associated with Broca's area being important for speech initiation and production, and Wernicke's area, which is thought to be more important for receptive language comprehension and understanding. So I'd like to start with this slide because if you think about what neuropsychology is as a field, we started as a true lesional field. We've advanced from there. However, when we're doing epilepsy neuropsychology, we largely remain to be a lesional field. So we're really focused on identifying specific deficits and assessing for hemispheric dominance. However, if you learned one thing and nothing else from this talk, I hope it's that you stop using the terms Broca's area and Wernicke's area and refer to them by their anatomical locations, which is a much more helpful way for neuropsychologists and neurosurgeons to talk about these. And hopefully by the end, I will have convinced you of that. So, we have different ways to localize function, and today I'll really be focusing on the neuropsychological exam itself. I'll briefly touch on WADA testing, and then I'll talk about electrical stimulation mapping, which remains the gold standard for testing cognitive function in the operating room and during extraoperative mapping for patients undergoing intracranial monitoring. I know that this is a very wordy slide. I'm not going to talk about every bullet point here, but I wanted to include it in case it was helpful. So when we think about the goals of neuropsychological assessment in general, we really have to tailor what we're doing to the referral question. So what I do for an epilepsy evaluation is going to be different than what we're doing for a dementia evaluation. So as I mentioned earlier, we're really focused on trying to identify specific deficits. And so, we need to be comprehensive in our approach, but, we do incorporate where we think the seizure onset is, the imaging, and we look at all of that as we select our.
I think you're muted.
That happens. Can you guys hear? I think it said the host muted me. Can you guys hear me again?
Yes, all good.
Okay. So one of the other most important things that we do as neuropsychologists is identify epilepsy comorbidities, which are often one of the most burdensome aspects of having seizures in the first place for our patients. And addressing those comorbidities is actually a very important component of seizure control in the long run as well. So we need to be comprehensive. We don't just want to do testing and look at those test results to inform treatment planning, because we need to treat the whole individual. So, in addition to administering tests, we always do the thorough record review. We select our tests, administer and score them, and then we go through a case formulation, which is really where our opinion comes into play. So when we present cases at conference, the main things that we need to answer are, is there a specific deficit? Where do we think that deficit is coming from? And is that consistent with where seizures are coming from? Because that's what's going to guide surgical decision-making ultimately. If we see deficits, but they have nothing to do with the seizure onset zone, that's not particularly helpful, and it makes it much more challenging for us to speak to what the relative risks of any destructive procedure might be. So that brings me to the limitations of testing itself, which is our tests are very sensitive, but they are not always specific. So we can easily identify if there is impairment present or there is a deficit, but we may not be able to say exactly why that deficit is happening. It could be due to multiple factors. We also don't definitively establish language dominance. We can see if patients have language deficits, but we don't know if the language is coming from the left hemisphere, even though that is usually the case. And so that's why we always rely on multiple pieces of information to establish functional localization. It is also an indirect measure of brain function. It's not like looking at the electrophysiology, which is a direct measure of neuronal function. So one other option we have is to perform a WADA test. And WADA has become increasingly controversial in the field of neuropsychology. So many sites have moved away from performing WADA, but many places still do them. So we do them here at Mayo Clinic Rochester, but there was a bit of a pause for a period of time for this reason. So people probably know that WADA testing is where we transiently anesthetize one hemisphere at a time and then perform tests to assess primarily language, but also memory. There are some limitations with WADA, of course. We have a limited window for testing before the medication wears off. And I think WADA is very useful for assessing language dominance. However, we have less invasive methods now with fMRI. fMRI is also an imperfect measure, and I could go on a whole tangent about that, but I will save that for another time. One of the other things that has become clear based on more recent studies is that WADA is not necessarily a great way to measure memory. So there have been studies that have shown that bilateral memory failure on WADA does not actually predict whether a patient will develop global amnesia after a destructive procedure to the dominant temporal lobe. I think there are probably a lot of reasons for this, but one of the main ones is if you think about how you test memory in WADA, if you're using objects, which is the most common way people show people, objects like a pen, a cup, and have them name them and then remember them later, that stimulus has both a verbal component and a nonverbal component. And so your stimulus is inherently testing in two modalities. That's probably not the whole story, but I think that's why a lot of people have moved away from WADA. So I actually do not perform the WADA testing here at Mayo Clinic Rochester. One of my other colleagues does, and she does a great job with it. And I think in many cases it is useful, but I think it needs to be interpreted with some caution when we see inconclusive results. So electrical stimulation mapping is, currently the gold standard for intraoperative cognitive testing, and it's increasingly being used in patients who are undergoing stereo EEG. We don't do as many grids and strips. I'm sure other places are doing fewer and fewer as well, just because of the increased risk. I I wish I had time to discuss passive mapping in this lecture because I think that's a really exciting thing that's going to be more common and coming on the horizon and eventually may end up replacing direct current stimulation mapping in some cases. But right now, I think most people rely on direct current stimulation mapping. Sorry, I wanted to make sure I wasn't getting muted again. I was getting an alert. So there are also limitations with electrical stimulation testing, of course. There's the risk of inducing a seizure, and then you're not able to do as much cognitive testing with that stimulation. Accounting for current spread, so you can get network level disruption. And then as Dr. Shi also alluded to, we're sampling. We're not able to test as much of the brain or as many areas when we're testing with SEEG. Because you're only implanting specific regions based on your hypothesized seizure onset zone. So the cognitive testing that you're able to do in patients who have stereo EEG electrodes implanted is really going to be dictated by what your sampling is. So as a neuropsychologist, again, going back to Broca's and Wernicke's area, the traditional language model of the Broca's area is important for producing speech. Wernicke's area is important for understanding spoken language and language comprehension, and is involved also in phonological decoding, so understanding speech sounds. And then, of course, those areas are connected by white matter. However, if we think about, the older language models, it's really insufficient to explain language deficits as a whole. And what I mean by that is newer models are taking things into account, like white matter that is not just the arcuate fasciculus, but the dorsal and ventral stream model. So the ventral stream is thought to be more important for semantic processing, whereas the dorsal stream is thought to be more important for phonological decoding and verbal fluency. So if we're thinking about what tasks we want to use in a patient with SEEG, we really need to think about what's going to be most at risk. Because if I'm just testing object naming and we're, testing more in the dorsal stream, we might miss something. We might not be able to identify what the potential deficit is. And so by being flexible, by selecting tasks that are going to be more specific to whatever that anatomical region supports or what we think it supports, we're going to get better information. And so that's why we call this kind of an informed matching approach, meaning that we're using the right tools for the job based on the functional anatomy. So, if we're testing the temporal pole, for instance, we think that's really important for not just naming pictures, but also proper nouns. Largely the middle temporal gyrus and inferior temporal gyrus should be important more for semantic knowledge rather than phonology. But if we're testing the superior temporal gyrus, we need to take phonology into account because it is more important for understanding non-speech sounds, speech sounds themselves. So by using things that are non-words, so conflical, for example, that's a completely made-up word, that's going to be able to pick up on phonology deficits better than using a real word like apple, which has a memory component to it. So patients can't rely on their memory if they're trying to repeat a made-up word. So here in Rochester, we use a testing platform called NeuroMapper that was developed by one of my colleagues and mentors, Dr. David Sabsovitz. He actually developed this while he was at Medical College of Wisconsin, and then we were fortunate to recruit him on staff at Mayo Clinic, actually the year I started my fellowship. So I was pretty excited because that meant I got to train with him. It's a very flexible platform. Hopefully some of you have seen this and are familiar with it, but it records not just accuracy, but also reaction time. So what we do is we baseline our patients on these tasks in our clinic before we take them to the OR or before we do testing with stereo EEG. And we give them a whole bunch of tasks with more stimuli than they're going to get correct. But then when we take them to surgery or we do the stimulation mapping, we only show them items that they got correct at baseline. By tracking reaction time, we can also pick up on early signs of cognitive decline in surgery because early slowing can be indicative of cognitive compromise. And yes, that actually is me in the operating room when I was a fellow training down in Jacksonville with Dr. Sabsovitz. So if anybody has questions specifically about the NeuroMapper platform or thinks they might be interested in using it, I did include his email down at the bottom. So hopefully we have time to get through at least a couple of these case examples. I won't take up too much time. So the first one is a 43-year-old right-handed patient with seizure onset at 28. He has focal aware seizures with language changes, including delayed speech and mixing up words lasting around 1 to 2 minutes. His EEG, scalp EEG, captured 4 focal seizures with left temporal onset, and his outpatient testing showed weaknesses in verbal learning and memory with normal visual memory. So if I were presenting this case at conference, what I would say is we have a 43-year-old male with a lateralizing profile suggestive of left hemisphere temporal lobe dysfunction. So we did implant this patient with stereo, 14 leads focusing on the temporal lobe. I think they put a couple sentinels on the right side as well. And when we did stimulation mapping, what we found was that when we stimulated the middle temporal gyrus, we induced some deficits. And unfortunately, my audio is not working, but in this case, what we saw was when we had the patient repeat non-words like barable, he did that just fine. However, when we had the patient answer very simple questions, such as, do monkeys live in trees? He would say no. Or does a football have wings? He would say yes. So what that tells me as a neuropsychologist is, okay, this area is not important for phonology. However, it's extremely important for language comprehension. I think most of us can agree that footballs do not, in fact, have wings, and that's not a correct response. So if we do something destructive in that area, he could be left with a very significant deficit. I think my slides paused. Okay. The second patient was an 18-year-old who also had left temporal onset seizures. Her MRI was non-lesional, but showed some possible blurring of the gray-white matter junction in the left fusiform gyrus. So very inferior, indicative of possible focal cortical dysplasia. So good candidate for a destructive procedure. I know surgeons always feel good when they've got a clear lesion to go after. So she also had SEEG implanted, and then this is her fMRI that shows where language is localized. And you can see, it is very involved in the middle superior temporal gyri, as well as the inferior parietal lobule. In her case, when we stimulated those areas, she could not repeat these made-up words despite having done that correctly just 10 minutes earlier before we stimulated the contacts that were implanted in the SPG. So that tells us we probably want to leave that alone because she could have a pretty severe deficit in that area. But it highlights, again, the discrepancy between how you test superior temporal gyrus function versus middle temporal gyrus functions. And then the last case, just to briefly touch on, this is published, so if you want to learn more about it, I encourage you to look at this paper. But this is probably my and every neurosurgeon's worst nightmare case. This is a patient with non-lesional frontal lobe epilepsy who had very, very high seizure burden. And we ended up taking him to awake surgery. We don't do awake epilepsy surgery very often for exactly this reason, because it's very difficult to determine where your resection borders should be. But obviously, this patient having about 100 seizures a month was really having a significant impact on his quality of life. So what you see here in the green is the MEG dipole clusters, and the red is where the SEEG onset was after intracranial monitoring. And when we took him to the operating room, I was primarily monitoring motor function and motor coordination. And what we saw was that every time we approached our posterior boundary and stimulated with direct current stimulation mapping, he would have disrupted hand coordination. And so that's really what guided our surgical resection and when we decided to stop. And thankfully, he continues to be seizure-free to this day. So hopefully I've imparted the importance of knowing how to test for what you want to test for and thinking really clearly about the functional anatomy that you're going to be potentially involving in surgery moving forward.
Thank you so much, Dr. Alden. That was a very insightful talk. Definitely, these are very, very important questions that our patients ask a lot about what to expect with different types of surgical strategies we may talk to them about. So our third speaker I'd like to introduce is Dr. Joseph Niemat, who is the Norton Endowed Professor and Chair of the Department of Neurosurgery at the University of Louisville. Dr. Niemat completed his medical degree from Duke University and then neurosurgery residency at Massachusetts General Hospital, followed by a functional neurosurgery fellowship at the University of Toronto. He was initially staff surgeon at Vanderbilt, where he was instrumental in developing many of their neurosciences clinical and academic programs. And since 2016, he's been neurosurgery chair at the University of Louisville. Dr. Niemat has received extensive grant funding, including NIH funding, and he has over 90 peer-reviewed publications. He was a recent president of the ASSFN, and remains highly committed to neurosurgical education and mentorship. So Dr. Niemat will be giving us a primer on how to think about surgical patient selection and some treatment options. Dr. Niemat?
Thank you so much. It's a pleasure to be here. It's a pleasure to present to this austere group. Thank you for having me. Are you able to see my slides? Okay, excellent. So here we go. So I'm going to try in just really a few minutes to kind of give you.
Sorry, we can see your screen, but not your slides.
Oh, maybe it's the wrong screen. Hold on, let me try again. Stop share. Let's try one more time. I thought I had the right. Let's try an application window. Is that better?
Yes.
Okay.
Thanks.
All right. Perfect. So I'm going to walk you through a brief algorithm for epilepsy surgery. This is something I started to put together very, very briefly here in my. Oh, I don't have them anyway. So these are my disclosures. So about 10 years ago, to teach residents and fellows, I put together a very brief algorithm. And even at that time, I recognized that really the field was changing very rapidly. What had been mostly surgical interventions, open surgical interventions like this. We did open surgery to identify a seizure focus by putting in grids, and then we went back and did open surgery to take out that seizure focus. And that was kind of the whole story. And that was shifting at first kind of to something like this with a series of MIS techniques, stereo EEG, laser ablation, and DBS and neuropace. But as I was asked to give this talk, I realized at first I thought, well, I'll just present these couple slides and we would be done now. But it's more complicated. I realized I better go back to the drawing board and sort of see what this looks like today, because I think it is changing sort of as we speak. This is what I came up with. And if you guys can just take a minute to memorize that, we can be finished and go right to questions. Or maybe I'll just walk you through some parts of it. So I've gone ahead and put together something where we walk through this and try to make it make sense. And I'll start just with a caveat. I mean, there are variances, I think, in even in the practices of colleagues that I know well, and we approach things a little bit differently. And this is a shifting field, so it is changing year to year. And so I think it is important. It was really a nice exercise to go through this and kind of rethink, okay, how do I actually do this today? And that's been fun. So the first step, okay, we've diagnosed epilepsy. We wouldn't be here if we hadn't. So let's, I'll touch on this very briefly, right? Because I think this has already been covered. But the definitions have changed a little bit. Typically we talk about as a seizure as a transient occurrence or signs of synchronous electrical activity in the brain, but it's two unprovoked seizures occurring more than 24 hours apart that is the diagnosis of epilepsy. That's shifted a little bit. You have the opportunity now to essentially diagnose epilepsy with a single seizure, and you can also essentially be cured of epilepsy. So you can resolve epilepsy if you've gone 10 years seizure-free, which is exciting. So it's important to know those. Classifications we've already touched on, so I won't go back into this, but it is important. As somebody who trained in the dark ages, I still am prone to saying complex partial seizures, and it's very hard for me to break that habit. But I do think the current terminology is somewhat clearer. So we've diagnosed epilepsy, yes, otherwise we wouldn't be talking about this. Is it medically controlled? That is really the first question. And I think, any patient that comes into my office or is referred to me, have we adequately tested medications? In a tertiary center, level 4 ILE center, we typically have, but it's worth asking the question, so what is medication response? What we typically talk about is this paper by Kwan and Brody that was published in 2000, and they prospectively followed a group of 500 plus patients and found that really after that first therapy, the response to second and third and fourth drugs yielded diminishing returns. And so you can see that here. Oh, there we go. If the first drug made 47% of patients seizure-free, the second drug only had an additional 13% of patients remained seizure-free, and just reduced from there. And so because of this, and this was actually sort of corroborated by a later study that they did in 2014 that showed that even with this very dramatic increase of the number of medications, it was, at the time that these studies were started in the 1980s, we had really just a couple drugs that we were using. And the question has been asked, gosh, we've invested so much money in new anticonvulsant medications. Surely we must be better at it now. And the truth is we really haven't. Those drugs are better tolerated. They certainly have advantages, but in the end, the seizure freedom rate is relatively similar despite all of these new medications. And so I think it's important to recognize that surgery still has a place for the time being in the way that we treat these patients. Furthermore, it is part of the AAN guidelines. I was involved in one of the committees that put these together a few years ago in 2014. And the recommendation is that if you have failed 2 medications or if you are continuing to have seizures for more than 2 years, you should be referred to a level 4 center. Yet still a huge number of patients really are not being seen. So this remains an important challenge for our field. Okay, so is it medically controlled? Yes, if those medications have worked well, then we're kind of done. We can follow those patients. As a surgeon, that's not where we typically get involved. What do we do when they're not medically controlled? Well, we should be referring these patients to a comprehensive center, and we have a comprehensive evaluation. We all put our heads together and try to figure out if that seizure can be more effectively treated. What does that look like? So really what we're trying to do is localize the seizure, identify what the seizure is, where it's coming from, and how it might be treated. I was taught that this is a 4-legged stool. I don't know if others have been given this, mnemonic or this memory tool, but this is what I teach my residents. And so, there are essentially the diagnosis of seizure localization rests on 4 sets of observations. The first is semiology. So what is the subjective experience? What does the patient describe when they have their aura or their seizure? And what is the objective appearance? Many patients do not recall their seizure. What do families say? What do we see when we do a video EEG in the EMU, et cetera? And that's the semiology. And that gives you actually quite a bit of information. The appearance of these seizures is is quite informative for at least how they are progressing through different parts of the brain. Imaging. So, is there a lesion somewhere, or is there sclerosis in the hippocampus, et cetera? Any variety of things can be picked up on MRI imaging when that's not effective. PET imaging can be meaningful to see hypometabolism in a region that is problematic. Further out, we sometimes do MEG or ictal spec. There are other imaging modalities that can be useful. We consider those sort of subsequent, rare interventions that we call upon when necessary. And obviously the EEG is very important. We had a wonderful talk by Jerry just a few minutes ago. But we're looking basically for 2 things. What is the interictal appearance of a seizure? We can do a brief EEG and see some of that activity, which gives us a hint about what area of the brain is prone to seizure activity. And then of course inpatient EMU stay where we actually get to witness the seizures and see how they progress through the brain is important. And then last but not least, neuropsychology. So, understanding essentially what disparities occur. There's a variety of tests that I certainly can't go into, and Eva covered very, very well. But understanding that also this is essentially an observation of what areas of the brain are dysfunctional because of the continued injury of seizures or the seizure process that's taking place. Typically in a comprehensive center, we sort of go through this process. We have an initial evaluation by the epileptologist. We admit the patient to the EMU. We get an MRI. We do whatever additional tests are needed, and then we have an epilepsy surgery conference where we discuss whether there's a meaningful intervention that can be performed. And proceed from there. So that's the comprehensive evaluation. In my mind, what we're really looking for when we look at that 4-legged stool is, are the findings concordant? So if we sort of see that they all hang together and they're pretty clear, at times that is sufficient for surgery. We see hippocampal sclerosis, we have a semiology that is, suggestive of seizures coming from the hippocampus. We have an EEG that also corroborates that, and perhaps that's enough to move forward. When they're not concordant or where they're not clear, we move typically to phase 2 monitoring. And so invasive monitoring, I'll talk about just very briefly. This has really shifted in the course of my career, at least in the US, when I was training and probably in the first 5 to 10 years of my career, we really were primarily doing electrocorticography subdural grids. Um, and that has largely shifted. Now, the stereo EEG was not new. We have these sort of famous pictures from Telerak that this was developed in the 1950s and really was the mainstay of phase 2 intervention in Europe really through the last 20, 30 years. It's really caught on in the US, I think for a variety of reasons. I think our conceptualization of seizure activity has changed. We used to think of it as sort of a single point, a single lesion that is, causing an epileptogenic focus. And we have really shifted to thinking of this as a network disease. And that lends itself to a stereo EEG approach where we are sampling more broadly. Jerry made the point, you don't know what is going on in regions that you haven't tested. And placing grids, you have the advantage of being able to map a single area very well and sort of know what the boundaries are. That's great. But you really don't know what's going on in the insula or what's going on easily in the hippocampus or in other regions that might be hard to reach with your grids from the craniotomy that you've made. And so that's really been a shift. It's also been, I think, really nicely demonstrated, and here's some of those techniques. This Kai Miller lended me this picture. I think, there are a couple really nice things about it. One is the information you get. The other is it is simply easier on patients. Anyone who has done both, patients look very rough the day after the craniotomy for their grid placement. Many of them look quite good, and you don't even have to do a full haircut in order to do stereo EEG. And so I think there are multiple advantages. This study by Sam Weeb, I think, is actually really meaningful. So this was 1,400 patients that were analyzed from the ILAE registry, and they looked at patients who had had grid placements and stereo EEG. And what they found both was that there were fewer complications whether or not propensity matched with stereo EEG, and furthermore, that stereo EEG was more apt to produce seizure freedom in the ultimate intervention. And so I think these, in addition to the comfort and the safety that we glean from it, the efficacy of it is also important. And I think this was an important demonstration. Okay, so we've done our phase 2 monitoring, hopefully either with phase 2 monitoring or maybe not even needing that. The findings that we have hang together, and we've identified a seizure focus, or we think we have. So, what are the possibilities? We'll talk really briefly about. So this is the idea I was talking about. So we've shifted, I think, our conceptualization. This was Jasper's view of what a seizure focus was. The epileptogenic zone was, an area around an area of lesion that was prone to creating a seizure, and there were spikes existing beyond that. Sort of decades later, this matured into sort of stages of zones. So you had an ictal onset zone, an epileptogenic zone, an area that had to be removed in order to provide seizure freedom, perhaps a lesion that was involved in this, an area that was eloquent nearby that would produce the symptomatogenic zone, and then further functional deficit zones and irritative zones, etc. Each sort of with a definition that sort of helped us understand a little bit about what that patient experienced during seizure and also not during seizure. But as I mentioned, that conceptualization has really changed from the 1950s to today. I think we really have moved from this idea of a fixed kind of tip of the iceberg identification. We know where the seizure is, and it must be this spot, to an understanding that there are regions that are communicating, and when you have zones with ictal dynamics that sort of lend themselves to seizure, that may exist in more than one spot, and stereo EEG helps us understand that. So there are different possibilities. As we've done all this testing, Have we found sort of an area that is focal or identifiable? Sometimes we do, sometimes we don't. At times we have a multifocal or a generalized seizure or epilepsy. In those cases, I won't go into great detail to divide. We could really talk all day about all of the different options that we have in generalized epilepsy or multifocal epilepsy and when it's important. But to give a general idea, I think this is really primarily where we're looking to neuromodulation. So I think in my mind, maybe the most dramatic change in epilepsy treatment in the last 20 years has been neuromodulation. This sort of began at the end of the last century. In 1998, we had this Handforth publication on VNS. I'm going to point out here, because I'm in part of my slide where I'm talking about generalized seizures, that these were done actually on partial onset seizures. Most of these neuromodulation studies were originally done not for generalized seizure, but for focal seizures. The same is true of the Sante study, and I know my time is running out, so I'm going to move a little more quickly. The Sante study using DBS to treat epilepsy, and then the RNS study again, always started in focal seizures. But pretty quickly, as we got good experience with this, we began to look at generalized epilepsies and can we use it for that? There were a large number of either case reports or small studies that indicated this, and this is a nice meta-analysis that reviews all of that data and suggests that, at least at the time that this was published in 23, the evidence that we had for VNS and DBS was that it could be used effectively in generalized epilepsy, and that I think was the practice of most surgeons. We've used VNS for generalized epilepsy since I started my career. Furthermore, RNS began to be used for for generalized epilepsy. This was a paper that we published looking at a large number that had been presented in the literature at that time. And there were small case series. Again, this is by Mark Richardson, demonstrating the use of central median stimulation for generalized epilepsy. This launched the Nautilus trial, which has not been published yet, but this is data that was released by the company. And so you can see that what they did see was a substantial reduction in seizures. And so that's positive. There's also been the Estelle trial, which is a DBS trial for generalized seizures. So again, all of these suggest that this is an important therapy. And at our center, that really has become the mainstay. When we have generalized or multifocal seizures, we are typically looking to neuromodulation before we look to things like callosotomy, even laser callosotomy or hemispherotomy or other interventions. You can see by sort of all these arrows here, there are a lot of different ways to go about this. And I think this is something that this is where the discussion and conference becomes really important. What suits this particular patient, given what we know of that patient? So getting to the good stuff. Okay, what finally we get, a seizure focus that we can identify. Is it resectable? I'll touch very briefly. When it's not resectable, there are still options. RNS was really created as a device to when you identify one or two seizure foci, but you cannot resect them because they are eloquent or they are bihippocampal. You can use this device in order to treat the seizures without resection. That's valuable. And certainly today we often consider broader strategies where we are doing this plus thalamic stimulation, et cetera. So there are lots of different ways to think about that. I'm not going to go, I have a little bit of information there on MSTs, which is used rarely, but still an interesting treatment and I think still valuable. What if it is a resectable lesion? What if it is not a classically eloquent lesion? How can you decide how to treat it? We have still options. There's open surgery and there's laser ablation and for now RF ablation through stereo EEG. In general, my algorithm is, is this focus small or well circumscribed? Can we identify it and feel that we can achieve a meaningful ablation destruction of it with a laser probe? In those cases, typically, I'll show you. I'm not going to go through all this data because this is a whole talk in and of itself. But certainly there's a great deal of data demonstrating that laser ablation approaches what you can achieve with surgical resection, and that the outcomes are well regarded, long lasting, and that they are accompanied typically with relatively short hospitalizations, lower complication rates, etc. So I think it is advantageous. If we look, this was a study that we did looking at the national inpatient sample and sort of seeing how this is progressing over a period of years, from 20, from essentially 2000 to 2018. And what we found was, the rate of surgical interventions really has not changed very much. We're doing, about 1,000 procedures a year, even though the number of patients being diagnosed and being seen as inpatients is increasing during that time. With the advent of laser ablation, we've begun to see that takes a little bit of the bandwidth of this, but it really doesn't appear to be meaningfully reducing the number of open surgeries that are occurring, neither of which really accommodates the population of patients who could be treated. And so again, if it's well circumscribed, I think that laser ablation is a very reasonable therapy. When it is a larger resection, when we identify that it involves both the hippocampus and lateral temporal cortex or larger areas of frontal cortex, we are typically moving toward still open resections, and that's how we typically proceed. So I'm sorry to rush through all of that. I'm more than happy to take any questions that people have.
Thank you, Dr. Nimad. That was a great organized summary of a very complex topic, and we all learned a lot from your, systematic march through that slide. So thank you for your insights. We'll open the chat for any questions if the audience wants to submit them. We have a little bit of time to get to them. But I'll start with asking the speakers, when semiology, EEG imaging, and the neuropsych data are not perfectly concordant, how do you prioritize this information in the surgical decision making? And what is the threshold to move to phase 2 SEG? How discordant does it need to be before pursuing that next phase of invasive monitoring?
Want to take that, Joe, or you want me to do it?
I'll give you my observation. I think there is tremendous variety in the way that centers approach this. I have had conversations with individuals at highly regarded centers, some of whom are relatively quick to proceed to surgery without that confirmation of stereo EEG. I've talked to other people who, essentially, unless there is a lesion on the MRI, everyone gets stereo EEG. I'm not sure we know a right answer. I'm not aware of strong enough evidence, and I'd be curious to hear from anyone in this group, from the other speakers or anyone in the audience. I think there's a lot of variance in it. I think each one is a judgment call.
Yeah, I 100% agree. I don't think there's a right answer. Certainly not any evidence-based data to suggest that you should follow this particular algorithm, and if this part works, then go ahead and proceed to resective, ablative, or neuromodulation, as opposed to, if you don't get this part, then you should definitely do a phase 2 study. Right. But I think in general, my concept would be, if I don't have a clear surgical hypothesis, which I feel confident on for a definitive procedure, I will more likely do further testing.
Yeah. Yeah, I would say that that there are times when we don't have I think you need a certain degree of certainty before you even proceed to stereo EEG. I've had a colleague who said, if you're placing more than 12 or 15 electrodes, you probably don't have a concise enough hypothesis that you really know, that it's time to proceed to surgery. I don't know if that's the right number or if it's more or less, but I do think that you probably need to have some good sense that you're going to test a hypothesis with your phase 2 monitoring in order to move forward.
Yeah, I'll add that I agree. It's a case-by-case basis. I think it's in my experience, it's more common that things don't align from a neuropsychologist perspective. It's rare that we see true focal deficits that perfectly align with our seizure onset zone because human beings are complicated. In those cases, I think it comes down to quality of life and what the purported risk is. I think in patients who have right temporal lobe onset epilepsy, we often don't propose SEEG. Because we assume it to be lower risk. Now, on the flip side of that, if we have good evidence that there's bilateral or contralateral language representation, then we might be a little bit more cautious. But every center does it differently, I agree.
Other questions?
Yeah, we got one in the chat. So for DBS for epilepsy, could you talk regarding your experience of the newer targets, like the anterior nucleus of the thalamus, centromedian, and pulvinar?
Sure. So I will admit that we do more RNS in the thalamus than we do DBS. Simply because our team really likes the feedback that you get, likes the information that you get from having the responsive stimulation and the readout of how many seizures have occurred. So certainly there is growing evidence that centromedian nucleus and pulvinar are valuable targets. We have used all of them, and we recently sort of engaged in a survey as to who was implanting thalamic stereo EEG. I think one question is, can we decide in our phase 2 monitoring which of these nuclei is most meaningful for this particular patient? There's some data that demonstrates that, just looking at the connectivity of the different regions, you can get a sense of, when a patient has a temporal semiology, that anterior nucleus or pulvinar are more valuable. When it's a frontal semiology, that maybe centromedian is more valuable. But I think that there's still a lot that needs to be tested there. And I think that there's a lot of value actually to be gained, both in research and perhaps in individual patients, to be used clinically by sort of exploring the hypothesis that we should stimulate one region or another. And I'd be curious to hear what others think. I think this is an area that is kind of an interesting ethical question at this point.
Sharona, we've done a few in central median as well as the anterior nucleus. I don't know, what are your thoughts?
Yeah, I think this is a really exciting frontier. We're of course amassing more and more data. So I think the truth will become clear, hopefully in the next couple of years as our level of evidence goes up for each of these targets. But yeah, we have had some great actual experiences at our center. For central median nucleus, I think pulvinar, of course, is the lesser studied of these three, but we're learning more and more about its potential function. I think a lot remains to be seen. For example, concepts around using stereotactic EEG to actually try to see signal in these particular areas, and then deciding whether or not to implant an individual nucleus based on that readout. And I think we still don't know the answer to that. We still don't fully understand. That's still a hypothesis that information is actually relevant, even though it certainly would seem logical that signal would potentially be a good marker for future success of stimulation, but we actually don't know the answer to that. So I think there's still a lot to be learned in these topics.
Yeah, I think the one point I will make, and I think Joseph, you indicated that you're doing more RNS implantation into the anterior nucleus of the thalamus, whereas originally it was more of, the DBS and the Santé trial. And I think using the RNS is important in the sense that you can get feedback, whereas with the DBS, you really don't get good neurophysiologic or electrophysiologic data. It's hard to get. You can get some, but certainly not to the degree that the RNS can get. I think my only concern, it's a theoretical one, is with the DBS, it's a pacemaker. So it's on, off, you stimulate accordingly, whether it's, 1 minute on, 5 minutes off, whatever. But the whole system is getting neuromodulated. So that epileptogenic network is getting electrical stimulation on, off, on, off. The RNS is only going to kick on in terms of an electrical stimulation if it detects, if it, meaning the RNS computer, detects what it thinks is a seizure. So if, for example, if we're implanting in the thalamus, and if the thalamus is relatively quiet, even with patients with focal seizures, if it's relatively silent, then that thalamus is not going to be stimulated by the RNS. It's a hypothetical concern. I don't think we have any data, but the reason I bring it up is I recently got a referral regarding a patient of whether we should put an RNS or a DBS in the anterior nucleus of the thalamus. So I think my only concern theoretically about the RNS is the fact that it's an on-demand sort of electrical stimulation system.
Almost by definition, you're not, you are not curing seizures. Your clinical seizures are reduced, but electrographic seizures, in some sense, whatever your threshold is, must be occurring in order for the device to discharge. I think it is fundamentally a different approach. The idea of DBS is you shift the state of the network into one that is less prone to seizure, whereas with RNS, theoretically, what you're doing is waiting for the seizure to happen. I think some hybrid is possible. I think we've done some work using AI to identify patterns of activity that suggest a seizure will occur, and if you could use that to trigger electrical stimulation and neuromodulation, then perhaps you could always keep the network in a state that is not prone to seizure. So a lot, I think, still to be developed.
Well, this is a very exciting topic, and we actually have a whole webinar planned around it. That will actually be part 3 of this series, so the conversation will continue. That was a really great session, really nicely distilled some of the fundamentals around some really a large swath of our field. Our next session will, part 2 of this series, will focus around intracranial EEG, talk a little bit about techniques, networks, and also talk a little bit more about stimulation and mapping and some of the details that go into surgical planning. That'll take place on May 6th. So hope you all will join us for that. I really wanted to thank our absolutely fantastic speakers this evening and our excellent moderators, and thank you all for joining us this evening.